Welcome to the American Shoulder and Elbow Surgeons Podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah in Salt Lake City. And I'm joined today by my co-host, Rachel Frank, a sports and shoulder surgeon at the University of Colorado in Denver. Rachel, how are you?
I'm doing great, Pete. How are you today?
Oh, everything's good. Before we get started, I should mention that views expressed in the podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society, the University of Utah, the University of Colorado, or the institutions of any of our guests. Okay, today we have a special translational episode for you. And I think we've all been hearing about cuff biology and how it's kind of revolutionized healing rates for years now. But suddenly there are actually a number of options on the market. So my hope here is to discuss a few of these options, understand the current evidence, get a glimpse into the future. And to talk about these topics, I've invited two experts. First, we have Dr. Brian Feeley, who's the Chief of Sports and Shoulder at UCF. Brian, welcome to the podcast.
It's a pleasure to be here.
And next we have Dr. David Kovacevic. He's recently been on the faculty at both Yale and Columbia. He's transitioned to private practice, but has a background studying amniotic fluids and rotator cuff disease, and I think has a lot of understanding of the basic biology here. So David, welcome to the podcast.
Yeah, thanks, Peter. Thanks, Rachel, for having me. I think it's going to be a great hour.
All right, so let's start, before we get into what's available on the market, let's start with what's available locally at the site. So Brian, we've heard for a lot of time about the local environment for healing and how we can maximally activate it. We've heard about microfracture. What are your thoughts? Are you microfracturing the tuberosity? How do you get the most out of the local environment without adding anything else in?
Yeah, I think that's a great question. In general, I think for the most part, especially as we've transitioned to smaller anchors, and therefore usually having more fixation sites and more places where we essentially drill into the greater tuberosity, I haven't typically done anything with any microfractures or any additional stimulation to get that so-called crimson duvet. Typically, if it's a large enough tear that I can fit 2 anchors in, I'll try to fit 2 anchors in, partially because I think more fixation is good, and more fixation, I think, leads to lower overall forces on the tendon to bone, which increases healing. And I think that additional bleeding is going to increase some healing. I'm also a little concerned when I start microfracturing to try to stimulate healing that I'll mess up and I will end up poking too many holes, and I'll end up creating something that I'm not going to be able to get good fixation with my anchors. Not that I've ever actually done that before, or maybe a couple of times.
What are your thoughts, David? Are you microfracturing the tuberosity? If so, how are you doing that? You're drilling? Are you using an awl?
Yeah, routinely I don't microfracture. The group out of Southern California has shown that does work well for them. As Brian mentioned, the crimson duvet. So, I think that one approach there is when you're preparing a greater tuberosity, if you've got a full thickness tear and let's say the entire GT is exposed, I think how you do bone preparation is critical there. So when you use that, the shaver there, or the motorized burr, are you completely denuding that cortical bone there, or is it just partial, or is it full? So everyone's different there. So for me, for my larger, massive tears that are repairable, I'd like to use the shaver. Sometimes the burr, if the cortical bone is really, really hard. Most of the time, though, in these like subacute and mostly the chronic tears, literature has shown, and you'll see that anecdotally intra-op, is that the GT, the bone quality, is somewhat poor. So you really don't need to use a motorized burr, but so I'll denude a little bit of that cortical surface there to get some bony bleeding. Sometimes I'll turn off the inflow, make sure that I'm pretty happy with it. And so that, in essence, we want to get that bleeding bed going there. And essentially for me, if I would microfracture, I'd like to be able to control the microfracture. So I'd likely use, a small drill bit or a K-wire versus using the awl, where, may not be as controlled, and especially in soft bone, poor quality bone, you may go too deep into the canal, which would not be good.
Let me ask you guys about acromioplasty. So this has been a hot topic for a variety of reasons recently in the last 5 years. But with respect to the topic at hand, There's been a big argument, long-standing argument for our knee surgeons that meniscus repairs heal more reliably with combined ACL reconstruction because of the release of marrow elements into the bone when you're drilling your ACL tunnels. Now, can acromioplasty play a similar role, or is acromioplasty not helpful for rotator cuff healing? David, let's start with you. Thoughts?
Yeah, I'd say that there's some good data. It's a little bit older data, but from Japan, essentially showing that once you do the acromioplasty there, that they were able to identify the factors in the cells that are available locally, and so you have your typical cytokines and some of your typical growth factors that are locally available once you do the acromioplasty. So does that mean that I'm going to be doing an acromioplasty on every single patient? Absolutely not. I try to make my decisions they're very patient specific. So let's say, for example, they have a massive rotator cuff tear. I'm not going to be doing an acromioplasty or a formal takedown of the CA ligament with an arthroscopic subperiosteal dissection there, because I'm really concerned about anterior superior escape. So regardless of how well you do the rotator cuff repair in a massive rotator cuff tear, we know that those inherently do not heal well. And if you release the CA ligament, which is an important stabilizing structure in these massive cuffs, you're going to, unfortunately put the patient at greater risk for failure of that, and potentially needing maybe a reverse if they do develop anterior superior escape because you iatrogenically took down the CA ligament. So for me, when would I do an acromioplasty? It would be more of my let's say what's my clinical exam look like? They've got positive Hawkins, positive Mears. Maybe they have a calcified CA ligament, and this is a smaller or medium-sized tear. And then when you go in there arthroscopically, what does the CA ligament look like? Does it look pristine? Does it look, injected, synovitic, frayed? As we know, from all of the chronic overuse that you're having, the CA ligament just has seen some damage. So in that sense, I'll do an acromioplasty in that situation. And so, yeah, I think that'd be great for healing in that sense. But the smaller tears, I don't worry about them not healing. It's more of the large and massive tears that concern me. So acromioplasty does have a role in my practice, but I use it selectively, and it's more a patient-centered, patient-specific decision-making process.
And Brian, how about you? What's the role for your acromioplasty in your cuffs? And do you think the same theory when we talk about ACL surgery and drilling the tunnels applies here with rotator cuff repair?
Yeah, I think it's a great question. I remember being a resident and kind of, let's see, from 2001 to 2007, and hating doing notchplasties and hated doing acromioplasties, because no matter how well you thought you did, an attending would always come in and do it better. And when I started doing hip scopes and doing femoral plasties, I felt the same thing. It's like, this is all parts of surgery I really want to eliminate. For acromioplasties, I left the acromioplasty burr back in New York, and I don't think I've done more than a dozen acromioplasties in the last 10 years, and maybe 2 or 3 in the last 5 years. In terms of whether or not it actually helps healing, I think it's different when you look at what you're asking in the knee versus what you're asking for in the shoulder. In the knee, you're asking blood to get to an area that isn't typically going to bleed meniscus repair. In general, if I'm doing a cuff repair, I'm looking at trying to maximize the tendon to bone healing and creating a watertight repair. I am really, really hopeful that any blood that's in the subacromial space isn't really getting down around my repair. Because if it is, then I don't think I've got a very good repair. So any of the augmentation strategies that I like to think about are going to come from bone up, not acromial side down. Now, do I have any good science to back that up? No, I don't think so. I think the data suggests that we don't need to do an acromioplasty in terms to change our outcomes, but there's no real downside. I think David's absolutely right. Like in some cases, the downside will be that you can promote anterior superior escape, but for the majority of the time, especially for small, medium tears where you just feel like you need a little bit more of a view, it's probably totally fine. But for me, I'm not going to use it to improve because I think if I'm using that to get to an area that I'm hoping the blood can't get to, then I'm not using the right rationale.
Yeah, Brian, I completely agree with you, and Also, David, I think your points are well taken. I guess my question here is, so to me, this is like where the biology first begins. We had this old argument from the knee, this old evidence from the knee. We had the evidence that David so adroitly brought up from Japan about the elements released when you do the acromioplasty. And then we have all these clinical studies when there's multiple randomized clinical trials that show no difference in healing rates. So I think this is a good example of how maybe you can make an argument in your head and find ways in which maybe it doesn't connect clinically. And you brought up maybe the reasons why about the fact that the acromion doesn't connect with your repair if you do the repair properly. I wanted to ask you the same thing about bursal stem cells, which are kind of the newest, hottest local adjuvant. And there's been a lot of talk about how you can, during your subacromial bursectomy, somehow take those contents and then you could trap them and put them back into your repair. What are your thoughts on this, Brian? Is this something that's going to change our practice? What does the future hold for this, in your opinion?
Yeah, I think the point of care stem cell treatments, I think, are as promising as anything else, at least at this point in time. So if you're thinking about like, well, where can I harvest viable stem cells, concentrate them, and then put them back in an area that's going to increase my healing, let's say 10, 20%, and be able to do that in a cost-effective manner. I think in the shoulder, you're looking at three potential places. You're looking at essentially from the bone marrow, so proximal humerus, which has had some variable outcomes, variable amounts of stem cells, but they're essentially bone marrow stem cells. From the bursa, which is going to include some of the fat in the area, so it's going to be similar to harvesting from the fat pad. And then other bony sources, which I don't think are nearly as viable. Some people have talked about doing distal clavicle harvest, which I think if you've already got the proximal humerus, you've already got it exposed, doesn't really make all that much sense. In terms of whether or not that's going to be the next great clinical avenue, I think the number of stem cells that are actually available that are truly stem-like in nature and whether or not they're going to promote healing, it still remains to be seen. But I think overall it's promising, and it's more than some of the, I would say, off-the-shelf options that are more frequently used.
What are your thoughts, David? I'm sure you've heard all this talk recently about bursal stem cells. Do you think this is the future?
Well, I think it's something that definitely needs to be looked at. So, I agree with everything that Brian has already brought up. So, I think that essentially this is a lot of the work that's coming out of Connecticut, with Gus Mazaka's group, and so I think that it's really important to do that. But the question is it really point of care? It's no different than PRP or BMAC, for example. What are we injecting? How much of that are we injecting? So when you're talking about, I don't like to use the word stem cells because that's a misnomer. When you look at the International Society for Cell Therapy, they've outlined some basic criteria for what a stem cell actually is. So I like to use the word connective tissue progenitor cells. And so, but if it's truly going to be stem cell-like, it has to meet three criteria. One is that these cells have to stick onto plastic. Second is, can they differentiate into bone, cartilage and fat. And the third thing is they have to express specific cell markers, right? So right now we don't have that point of care test intraoperatively where we can determine all of this. So can we harvest subacromial bursa on every single rotator cuff repair? Absolutely. Can we in the back table spin it down and isolate it and break it up potentially with some collagenase in the back table? Absolutely. But what are we actually injecting? And then when you look at the cost curve, are we actually improving what we're looking for, which at the end of the day is, can we improve structural healing rates? So I think it's a great idea and it needs to be further explored. But again, it's going to require some type of point of care test and some safety. I think safety and efficacy you don't have to worry about, but we're talking about effectiveness. That's a different question. And so, you're going to have a really good control group, and then you have this experimental group. And you'll have to be able to show that the structural healing rates, can be improved with the addition of these subacromial bursal connective tissue progenitor cells. And so, that we're not there yet, but I think it's definitely exciting, and there's a lot of groups that are looking at it. So something that definitely I think we should be on the lookout for in the future.
Yeah, I'm going to butt in because this brings up a really good point. I think David's points are a few really good points. First, what we call stem cells is very variable, and what the general public calls stem cells, we probably shouldn't be calling stem cells. These should be called exactly what David said, connective tissue progenitors. But that doesn't necessarily as fancy for patients. I think the other thing in some of Gus Mazaka's studies is really interesting is the people that you would probably most want this from are the ones that have the least viable stem cell or connective tissue progenitor. So especially older patients have a much more difficult time forming colony forming units. So even though these connective tissue progenitors are there, they may not be as viable. And then what hasn't been explored are these other patients that we really think are going to be the ones that need these augmentation strategies. People with comorbidities, they're older, they've got bigger tears. Are these cells going to be as viable for these patients? Because if they're not, then we've got the wrong strategy for the wrong patients, or the wrong strategy for the right patients. And we really need to be able to drill down and look at efficacy on an almost case by case basis, which is going to be hard to do with the appropriate cost right now. But hopefully in the next 5-10 years, we'll be able to delineate some sort of point of care efficacy by looking at some subset of these cells at the time of harvest.
Yeah, and the other thing to add there is, with these, the chronicity of the injury, right? So what is that? What is the homeostatic state of the bursa in an acute injury state versus a subacute versus a chronic? And then you throw in their age, and then you throw in the medical comorbidities, and so all of that, it's hard to really understand, what you're getting. So you're right. You're absolutely right, Brian, in terms of I've got like a 70-year-old patient. I want to use their subacromial bursal cells, but will these cells actually respond, or are they just going to remain quiet and they're not going to be able to differentiate into a fibroblast or into a tenocyte, right? So these are the challenges. So there's definitely things out there that are available now that we can do, but are we actually making an impact? It's hard to know right now. And I think one of the things that's really important here for our listeners who are our trainees, so our medical students, our residents, our fellows, there's a lot of data out there. So how do you kind of swim through all of that and come out on top? And so I think this is where clinical practice guidelines, particularly with the AOS and what they published in 2019 with regards to rotator cuff healing, is really important, because I think that at least sets a baseline and tells us what's been done over the past 5 to 10 years and how good that evidence is, and what are some of those recommendations, right? So, and what the 2019 guidelines show is that biologically, there's a lot of work that needs to be done. And so I think that's what's exciting. And I think, we'll see what happens the next 5 to 10 years when the CPG gets updated. But if I was a resident, that would be my starting point, understanding, do I do marrow stimulation techniques? Do I not? Do I use some type of biologic? Do I not? Do I use some type of scaffold? Do I not? Does it impact patient-reported outcomes, or does it impact structural healing rates, right? So some of these biologics do impact the structural healing rates for the better, but they haven't shown to show differences with regards to patient-reported outcomes versus your standard repair.
I'm confused. I thought all the residents were reading OKU and staying up to date the whole time. Is that not what's happening?
I'm not sure. I think you'd probably know better than me, but there's a lot of resources out there, right? So,
well, we have some of your former residents from Columbia. They seem pretty well read at this point, at least.
No, they're awesome. And I hear they're doing a fantastic job. So they're
at
great.
least one of them is. At least one of them.
I got an idea. I got an idea, but no comments.
Let me ask you guys, following up on this, in addition to bursal cells, there's a lot of other potential sources of cellular elements in the body that are point of care, autologous, and available. Do you guys think that there is any utility in using autologous treatments from elsewhere in the body, such as bone marrow or MFAT or PRP, at the time of rotator cuff repair? Do you think that these different autologous sources need to be concentrated? How do you apply these sources, if you do, and when do you do that? Brian, let's start with you.
Yeah, I wish I could say, as somebody who talks a lot about biologics, that I use them, but I've never figured out how to effectively use them. And part of that was based on my experience as a fellow. We were doing a study with Dr. Rodeo, and it was, I mean, for lack of a better term, it was painful to put in fibrin clots and PRP at the time. Our techniques have gotten better, but I still haven't seen a way that that doesn't wash out within the first hour, 2 hours. So I think it's pragmatic. Cells that we either concentrated or not concentrated, we put under a repair. I'm not convinced they actually stay there. I think for me, clinical use would have to be in some sort of scaffold or some sort of method to keep the cells viable and either secreting or stimulating the local environment for a period of 6 to 10 weeks for me to consider it truly a biologic regenerative strategy for tendon to bone healing. So for me at this point, I don't use any additional cells. Even when I consider what sort of augmentation strategies I would like to do, that my algorithm doesn't enter into cellular-based therapies. It bridges more into patches, grafts, or if things are looking really bad, a tendon transfer, because I don't think we can take something for like PRP or BMAC and say, well, it's gonna work for absolutely everything in the body, so we're going to try it on rotator cuffs, even though nothing else is really held for rotator cuffs. So my go-to for large chronic tears is not going to be something that's a biologic strategy at this point.
And David, how about you? Similar thoughts, different thoughts? Is there any time that you'll use some sort of autologous cellular source, whether it be bone marrow, fat, or PRP for your rotator cuff repairs?
Sure. Yeah. So short answer is that I don't routinely do augmentation. If I was going to do augmentation, what are my indications? So someone who's over the age of 65, someone who's a smoker, but again, you know, I would want to know what their urine creatinine levels are before, and we would have a frank discussion about trying to mitigate nicotine use for the first 6 weeks after surgery, knowing that the first 3 months in these large massive tears are critical for healing. Other folks would be those with autoimmune disorders, folks who are on oral corticosteroids for some reason, you know, whether it's for chronic asthma or maybe sarcoid or some other things. And then obviously, like, how many cortisone injections, right? So I typically limit one cortisone shot in these degenerative rotator cuff tears, but sometimes you will get patients in your office who've already had multiple cortisone shots. Even though there's some great data now coming out of special surgery, that retrospective review, but showed that more than one cortisone shot, you know, deleteriously impacts rotator cuff tendon to bone healing. So in terms of if I was going to use to augment the repair, it would also be in my larger tears, my repairable tears, where I can at least bring the tendon over and cover at least 50% of the footprint. My goal is to try to cover the footprint 100% all the time. Of course, that's not possible, right? So in these chronic injuries where you have more tendon retraction and there's some muscle changes. And so if I was going to augment it, of course, you can use BMAC, you can use PRP, and then you could also harvest fat, whether it's from their abdomen. So I think that for me, I don't, you know, again, I like to look at the evidence. What's the best available evidence out there? And quite frankly, PRP just, you know, hasn't held to that standard where I can say that consistently it's gonna, you know, be coming out to the top and be the cream of the crop. It's just not. The Koreans have shown consistently that using pure PRP gel will improve, you know, structural healing rates. But when you look at some of the other places around the world, that's not necessarily the case. And in terms of impacting the patient-reported outcomes, really there's no differences whether you use PRP or you don't. And so knowing the type of PRP that you're using is also critical, right? So the platelet-rich fibrin matrix that Brian talks about with his time with Scott, Scott Rodeo, they showed that delivering platelet-rich fibrin matrix actually increased failure rate. So there was a lower structural healing rate. I think it was about 40% of their repairs there did not heal. And I think they used ultrasound as the way to assess healing there. So for me, if I was going to use PRP, I'd be using pure PRP gels. I wouldn't be using pure platelet-rich fibrin matrix. In terms of BMAC, we just don't know. There's just not enough there. Nicholas Piuzzi, I'm probably mispronouncing his last name, but from the Cleveland Clinic, they've done a really nice systematic review showing us that, again, with BMAC, no difference than PRP. We don't know what we're injecting. There needs to be a standardization of the methodology. And then the last one, I'm just not, I'm not going to harvest fat. So for me, if I was going to augment, I'd use platelet-rich plasma, and it'd be a PRP gel type, and I'd interpose it at the interface because that's where the best data is right now that we have published out in the medical literature.
Okay, I've got a question for any of you. Why do you think that we can show better structural healing, but we don't see improvement in patient-reported outcomes? Do you think that's the quality of the repair? Do you think that's just our subjective differences in patient-reported outcomes aren't granular enough, or is there something else we're missing?
I think that's a great question. Yeah. I think it's a great question. I think it's a real question that's plagued the cuff literature for a long time. And I think there's a lot that goes into it. And I think if you look carefully at the questions we ask in our patient-reported outcomes, they're so driven by pain that I wonder sometimes if because the pain relief is so good with treating the biceps and a partial repair, that that obscures much of the effect of maybe 100% healing. The same is true for debridement, and the same may also be true because of the length of the outcomes, and that the longer you follow the patients that are treated with a cuff repair that doesn't heal, the worse they do. And I think that Moosemeyer has shown that pretty clearly. I also wonder about the responsiveness of our outcome scores, and I think that there's more work to be done there, but certainly that's difficult work to do, and I don't mean to act as though the work that's been done so far is for naught. I mean, I certainly have a ton of respect for all the work that, for instance, Mattson put into putting together the simple shoulder test, and that our own society put into creating the American Shoulder and Elbow Surgeon score, which I think is a good score. What were you going to say, David?
Yeah, no, I agree with everything that you guys said. I mean, that's the conundrum. Like, why aren't the patient-reported outcome scores correlated with the structural healing rates? And I agree with Brian. I think that these patient-reported outcome scores are just, it's too much of a blunt instrument. And so I think that when we talk about, did the patient achieve the minimally clinical important difference? And I think that the majority of the patients probably do. So you should probably be looking more at the substantial clinical benefit instead. If 80% of your patients are all meeting the MCID, that's the bar, right? So for me, it's more of like who hasn't met substantial clinical benefit. It's almost like analogous to, the rugby players that I care for. And essentially we talk about return to play versus return to performance, right? So return to play, I think, would be like meeting the MCID. Return to performance would be the substantial clinical benefit. So I think that a lot more work needs to be done on that. And I think that when you look at a lot of these studies, like these RCTs that have been done, these are hard to do. They're very expensive. They're the best data that we have out there, level 1 evidence or level 2. But the MCIDs are flawed. So I think like when you design the study, and if it's based on a change in the PRO for the rotator cuff, it's going to be hard because I think that we have not determined the appropriate MCIDs or the substantial clinical benefit, for these disorders. So the problem, like we looked at this for a massive rotator cuff tear research group with the ASES Merit, for example. And so I think, we use the baseline, and you can look at the literature, and it's like, for the ASES, it's like 20 or 30 points, and there's a difference between physical therapy and repair. And alternatively, the constant score, right? So it's like 17 and 34 for physical therapy and repair, respectively. The challenge here, though, is that, our group believes that for each surgical treatment strategy, there's likely a unique MCID and or substantial clinical benefit. So again, a lot of work that needs to be done, but I think that's maybe how you might be able to actually show some differences in the future. But you won't know that until you actually do the work. And so, but I think that's exciting stuff. So how do you marry the clinical research with the biologics work? It's hard. It's hard. I think rotator cuff research, clinical research can be challenging because of what Brian mentioned.
But I think it's even more than that. I mean, if you look at the average ASES score after a rotator cuff repair is about 90. And as you mentioned, the MCD is 20 to 30 and the max score is 100. So it's actually not possible to power a study to show an improvement of the MCID because of a ceiling effect within the score itself. What are your thoughts on this, Rach? I mean, I know you've done a lot of research on stem cells, and I know you've done work recently with the MCID. How do you navigate around this in your own clinical work and research work?
Well, I think this is such a hot topic, and I'm glad we're discussing this. And I love that we're talking about the MCID, particularly as it comes to rotator cuff repair and outcomes. I kind of think of the MCID, whether it's for cuff or instability or any procedure or treatment that we do, as just what David was saying. It's almost like it means just good enough. Well, we hope and expect all of our patients to do well, but we need them to get back to what they love to do. And so when we rely on scores or outcomes such as the MCID, we're just saying, okay, if they met that, and maybe this is an insurance thing, and we're trying to prove that what we do is good enough, so it's worth doing the surgery, and that's why our papers are potentially powered to find the MCID for a certain outcome score. I as a surgeon, and I think all of us feel the same way, we're not hoping for good enough. We're hoping for awesome, rock solid, excellent, back to golf, back to soccer, back to whatever they want to do. And so I am conflicted with MCID because we want to know that we're good enough, but we're not striving for good enough. We're striving for excellent. And so I totally agree. It's like getting back to sport, but getting back to the same level as what you had before your injury or intervention is really what we're interested in. So we have a long way to go. And I think the cuff is probably one of the more challenging areas in which to explore this, simply due to the fact that outcomes don't correlate with imaging findings with any sort of frequency or predictability that we know of. So I guess I don't have a good answer to that question, Pete, but I would say that we have a lot of work to do, a lot of area of, interest from, especially our young listeners. If they're interested in getting research grants or starting projects to look into these areas, this is an area that's ripe for new study and investigation.
Well, let's move on. I want to talk a little bit about growth factors. So we've heard about, growth factors you take from the body and you concentrate somehow, but there are some now commercially available growth factors recombinant. Of course, there's BMP, which we've used for a long time in fracture and for spinal fusion, and people have used in off-label and other circumstances. You can also now get platelet-derived growth factor, PDGF, which there is some evidence for in the cuff on the basic science side. So, Brian, tell me your thoughts. Is there any role to put these growth factors that you could just buy? I mean, you could do this right now. You could buy these. You could put them in your cuff repairs. Is there a role for that? Is there going to be in the future?
Yeah, I think it's interesting. Some of the research by Johnny Heward, he's been at a variety of different locations, but I think it was back when he was at Pitt, looked at what is really important in PRP. And one of the things that kind of rose to the top was platelet-derived growth factor. The problem is even though platelet-derived growth factor or a variety of other things kind of rise to the top, I think it's too simplistic of an approach. And I think we can see that in a variety of different settings where you're asking your body for a rotator cuff tendon to heal to basically get as close as possible to recapitulate what happens on an embryonic state. And even if not, to at least get close enough to stimulate some sort of tendon to bone healing that has some scar tissue formation that's fibroblastic, but also has some true tendon to bone fibers, or at least approximates that. Platelet-derived growth factor isn't going to do any of that. Neither is any other simplistic cocktail of 3 or 4 growth factors. And then I think the cost of it is going to get prohibitively expensive. And the reality is, I don't know how much to add. I always am concerned by that initial study by Scott Rodeo and others during that time that showed too much of a good thing actually inhibited healing. So unless I have that data, these single growth factors are going to remain not in my wheelhouse. And I know I've said that for every biologic that we've talked about so far, but I really just don't know. I don't know how I would justify using it at that additional cost over improving the biomechanical strength of the repair, or going a little bit slow with rehab, or cutting the biceps and making sure they don't have biceps pain afterwards.
What are your thoughts, David? Is this the future, or is this just too simplistic, as Brian says?
Yeah, no, I agree with Brian. It's too simplistic. So I think that single factor therapy is probably not the solution. I mean, our preclinical data supports that, showing that, you know, single factor therapy is not the way to go. It's more, you know, where you have tissue engineered constructs essentially. So, you know, something similar to what one of the things you mentioned, Peter, like, you know, that Purdue, you know, essentially like a cancellous bone allograft, right? So you have the unmineralized fiber cartilage and the mineralized fiber cartilage from cadaveric specimens, and sounds like this is now being tested in humans in a clinical trial in Chicago at Rush. So I think that here the most important thing is that you need the cells, you need the scaffolds, you need the growth factors. And so, you know, a lot of folks have shown this, and I think that's really, really important. So for me, just like Brian said, you know, using only PDGF or TGF beta 3, for example, is not the panacea here. Really, it's about, you know, what David Mooney from Harvard has shown, is that, you know, you build these constructs that they hydrolyze at different time points during healing, right? And so this is where, you know, what Brian mentioned, you know, the first, he wants something that's going to be able to elute over a 6-week time period, right? So identifying the growth factors that are most responsible for minimizing inflammation. Some inflammation is important, but minimizing the bad inflammation and optimizing the good inflammation, and then, you know, bringing all the other building blocks and players on board, you know, during those first 6 weeks, or could even be up to 3 months, especially for these massive tears, because, you know, the guys from University of Michigan and Cleveland Clinic have shown in their elegant studies that all these repairs, they all stretch out, right? So at 1 year, they all stretch out about 1 centimeter. So how do we, you know, minimize that tissue creep and minimize that fibrovascular interface tissue? So it's going to have to be a multi-factor therapy using a tissue engineered construct.
Let's move on to a different topic that both Pete and I are interested in, and this is interpositional patches. Now, we're not talking specifically about dermal allografts or xenografts that you put on top of the cuff, or using, for example, as an SCR or a bridge between an irreparable cuff and the tuberosity. We're discussing a patch that you put between the tendon and the bone as essentially a sandwich for a repairable tear. There are a few commercial products available. Wondering if these are part of your practice, and should we be using these on all tears or any tears? And if so, which ones are they? Brian, let's start with you.
So I love the idea. So I think when we look at where we have failed in biology, well, none of us hopefully failed biology, but we failed in rotator cuff healing is augmenting that tendon to bone healing. And I look at what makes the most sense is to have something in between tendon and bone that's going to be somehow bioinductive and stimulate some sort of increased healing. And as just said, we need to decrease the time it takes to heal so that these repairs stretch out. And going back to why people can look healed on imaging, but probably aren't doing quite as well or different with patient reported outcomes, is I think those studies are right. I think these repairs stretch out, and in some patients that repair gets so thin that it's not essentially holding up, and it's too thin to actually carry any load. And those are the patients that say they feel different, but not necessarily better. I think when you look at the two places where we can put a patch, we can either put it underneath or we can put it on top. And whether or not that's some sort of tunable scaffold or something that's just simple, and then that adds a little bit more for essentially either to maintain cells within that environment, to maintain a more a buffer for an environment for healing. I think over the next 3 to 5 years, those are going to become almost commonplace, especially as the cost for those come down.
And David, how about you? What are your thoughts on these?
Yeah, so these interpositional scaffolds. So the way I like to conceptualize these, if I was talking to my patients, or let's say to trainees, would be, is this more of a biologic scaffold? Is this a mechanical scaffold, or is this a hybrid, biologic plus mechanical? So a lot of them, to me, that are available right now on the market, they act more of such as like a biologic scaffold, right? So you look at Biologic, so I believe like Zimmer is device company that offers that. I have no conflicts of interest with Zimmer whatsoever. So, but the point here is that you've got an anchor, and it's a fenestrated anchor, and there's a little bit of scaffolding material that's there. I think it's like a PLLA or a PLGA or composite. But essentially, I've never used that anchor before, but I really don't think that type of anchor is really going to move the needle, because essentially, the anchor is like 4 to 5 millimeters in diameter, and the scaffold, is just a few more millimeters larger than that. So like you're talking about a mat, like let's say like the GT is completely exposed. So each patient's different, but let's say you've got from anterior to posterior, you've got about 2 centimeters of that greater tuberosity that's exposed. It's a full thickness tear with tendon retraction, and so you're not going to really be able to cover up enough of that footprint with this, the biologic scaffold, right? So to me, I don't think that really moves the needle, and whatever additional cost that is compared to a standard anchor, it's not going to help me. I think you're looking at some other biologic scaffolds. I think one that's intriguing is human amniotic membrane. That's something that we looked at in the lab. There's a lot of different studies, mostly down in the foot and ankle literature that shows some promising results. But again, these are, extra-articular tendons, and the rotator cuff, has an element of it being intra-articular, particularly if it's a full thickness tear, and the capsule is fused with the human rotator cuff tendon. So human amniotic membrane, I think, again, acts as a biologic scaffold, doesn't give me that mechanical strength that I need. And that's why I think, Peter mentioned the bioenthesis. So to me, that's more of a hybrid of biologic and mechanical scaffold. So, I'd like to know a little bit more about that. Peter, what do you know about that, since you brought it up? And I think the folks at Rush are testing it. Is that correct? And, is it available for use, let's say, like, surgeons in the U.S. right now?
I believe the bioenthesis product is commercially available. I haven't used it. I have used the Biologic product. I should mention that our research program has received some financial support from Zimmer specifically to test that anchor. So I have used it in that setting, it's the little pad that you get. We called it the lily pad that comes out of the anchor, is actually slightly larger than the anchor. But I think what you mentioned is true, which is it's certainly not large enough to cover the whole tuberosity. And thus far, I'm not aware of any evidence that it's better. I know Zimmer has done that study, but I haven't seen the results from it. You mentioned amniotic membrane, and that's something that I don't know a lot about. Brian, I know you've done a ton of work here on biologics generally. What are your thoughts on amniotic membrane or amniotic fluid? Is this going to be the place for it? How would we use that?
I'm going to defer that one to David, since I think he published using human amniotic membrane in OJSM, I think 2 or 3 years ago. So I would defer to David on this, as he's the expert.
Yeah, no, thanks, Brian. Yeah, listen, I think it's promising, right? So I think that the next step would be, the problem is like delivering it. So it's very thin. The nice thing is that it comes in like large sheets, but I consider it like as thin as a Listerine strip, essentially. And so the handling of it, you're a little bit concerned in a wet environment. I believe there are some clinical trials being done in Texas with this material, human studies, rotator cuff repair, but we don't know what the results. There's no like interim data that's been published yet, and there's been no guidance yet, right? But so I think, generally speaking about human amniotic tissue-based products, I think the rationale for it is that it has certain proteins in there, for example, like TGF-beta-3, that help decrease the amount of scar that's formed at the interface. I mean, that's what we showed in the animal model, was a massive rotator cuff, chronic massive rotator cuff injury and repair model in the rat. We did find that essentially that the attachment site histologically appeared more normal, or recapitulated the four zones, right? The tendon, the unmineralized fiber cartilage, the mineralized fiber cartilage, and bone. But I think that like using it, you can use it clinically. There's no issues with that, but you have to be careful about like off-label uses. And so there's different types of amniotic tissue-based products. There's ones that, is it dehydrated? Is it decellularized, right? So we found that the human amniotic membrane does have cells in there. I mean, it's been dehydrated, but these cells are dead, but they could still respond, right? And so then you also have like micronized, lyophilized human amniotic membrane, and that's considered more than minimally manipulated. So that would be an off-label use, and so that's not good. You need to know like what you're using with these human amniotic tissue-based products, and then there's a lot of gray areas, I think, with use. A lot of different companies that provide this product. I'm not wedded to one single company over another, but it's something that I think has promise and needs to be investigated more. You could use umbilical cord as well, so that material is a lot sturdier. It's got 3 layers, and so I think that would in a wet environment arthroscopically would fare a lot better than just human amniotic membrane alone, which is as thin as a Listerine strip. But yeah, I think that's where I stand with that. Like I said, I think the bioenthesis, I think that's really, really intriguing device because it has the potential to load it up with growth factors as well as cells, and so I think that's pretty interesting there. What are your thoughts? Do you guys know anything about that at all, Peter or Rachel, about the bioenthesis study at all?
I don't, but we're going to have someone on to talk about it so we can learn more about it. We've covered a ton of ground between, like local factors, growth factors, PRP, patches. Is there anything else, David, that you can think of that's on the horizon that we missed? Anything else you think the listener should be on the lookout for?
Yeah, no, I don't think so. I think you guys have hit the nail on the head, and I think there are some other companies, like BioRes is another company. They're based out of New Haven, but they're looking at essentially some they call it like their BioBrace, but essentially like a PLLA type biocomposite that's porous, and so the idea here is that you can use it potentially for like extra-articular ligament repairs, extra-articular ligament reconstructions, and then perhaps as an onlay for rotator cuff repairs. And again, I don't have any financial, I'm not conflicted with them whatsoever, but it's something that you might consider. For example, like where would you use, maybe perhaps their product, it would be like if you had like a mid-substance rupture of your rotator cuff tendon tear. So you have all this tendon tissue loss, and you really don't want to do an SCR. And it could, it only involves a supraspinatus. And so you can either use hamstring tendon allograft, which I've used in the past for a similar case like that. And this has been described, from one of the professors out in Australia. But, essentially, works in the same fashion. You get more length laterally, the muscle quality is good, and you're able to reattach it to the greater tuberosity. So a lot of these companies exist, and I think that for the trainees listening to this, as well as the orthopedic surgeons in practice, anything that for me, the take-home points at the end of the day for the listeners is you need to really understand what the latest evidence is. You need to know your tissue source, the graft type, the processing technique, and most importantly, counseling our patients, educating them, and this is a shared decision-making process when you're considering using all these orthobiologics. So, and really it comes down to like, are you an early adopter or a late adopter to technology? So everyone has to go through those questions in their mind. Am I gonna, use some of these newer products now, or should I wait until there's more evidence? Me personally, I'm more in the middle. I'm not the last one to the party, but not the first one either with regards to adopting new technology. So those are my last thoughts for tonight.
What about you, Brian? I know you guys have been hard at work on this UCSF. Any glimpses you can give us into a future, things we may have missed, or anything else you'd add?
Yeah, I think I'm biased because I think a lot of these commercial things have some promise, but I don't think we're anywhere near recapitulating what the body can already do. So I honestly think the next step forward is going to be being able to stimulate your own stem cells, or for rotator cuff patients, those that are remaining within the bone, tendon, and muscle, and leveraging either local stimulants or pharmacologic treatments to stimulate those tendon stem cells, bone stem cells, muscle stem cells to regenerate at the time of repair. I think that's actually going to be more promising and probably a considerable amount cheaper than putting a patch, scaffold, or umbilical treatment in. That being said, I think the things that to the party with a lot of different options, meaning they have cells, they have some structural capabilities, they have growth factors, are going to be much, much more promising than a single growth factor or a single sponge that's going to be able to be used in 9 different body parts.
All right. Well, I'm sure with this crew, we could go on for another hour or more about everything going on Biologic with the rotator cuff, but that is all the time we have for today's podcast. We want to thank our guests so much for sharing their insight and their knowledge with all of us and our listeners. I'm sure this is going to be a very popular one amongst our podcasts. For all our shoulder and elbow listeners out there, please don't forget to subscribe. And for Pete Chalmers, I'm Rachel Frank, and we'll see you next time.